Welcome everybody to this annual general meeting of the Surrey and Sussex Healthcare NHS Trust, SASH as we usually call it. My name is Richard Shaw, I'm the chair of the trust, and I'll just be chairing this AGM this evening. We do very much value your interest in the trust and your support, so thank you for joining us this evening. This is the second AGM that we are holding entirely virtually. And this is partly because even though restrictions have lifted in much of society, we are still maintaining infection control practices within the hospital. And that's why we are all distant from each other this evening and all wearing masks as well. We do hope that the technology behaves, but if at any time you experience problems, please be aware that we will be uploading a recording of the meeting tomorrow, so you can watch it on our website link if you wish. So over the course of the next 90 minutes or so, we'll be sharing reflections of the last year. We've a lot to be proud of, but all of our thoughts are with those who've been most affected by COVID-19, both patients and our staff, and particularly those who've lost their lives, including our friends, our family members, colleagues and patients. The last part of the evening will be dedicated to questions, and you can ask questions anytime from now. So there may be a delay of a minute or so in the feed that you're watching, but if you do have a question, please don't wait to ask it. Write your question in the chat box and we'll try to answer as many of them as we can across our panel. So today we have our Chief Executive, Michael Wilson, here. We have Paul Simpson, Chief Finance Officer and Deputy Chief Executive. We have Ed Chetty, our Medical Director, and Tony Newman-Sanders, our Chief of Cancer and Diagnostics. We are also joined remotely by Jane Dixon, our Chief Nurse. The agenda is quite a brisk one, so Michael is going to begin with a quick resume of the last 12 months. And then Jane Dixon and Ed Chetty will introduce a session on reflections. And the highlight of this is a short film which comprises short clips of comments from our staff across the organisation. I've had a preview of that and I found it both moving and inspiring, because all that we do is achieved by our staff, and it's been a very challenging 12 or even 24 months for our staff. Paul Simpson will briefly cover our annual accounts. Tony Newman-Sanders will talk about developing diagnostics and some of the investment that we just made, and then we'll come to questions which the panel collectively will answer. So without any more to do, I'm going to pass over to our Chief Executive, Michael Wilson, to give us a quick resume of the last 12 months.
Thank you, Chairman. Good evening, everybody. So, as Richard said, last year really has been like no other year. It's been a really tricky and difficult year for the whole of the NHS, but particularly for us here at SASH. The pandemic presented with us a huge number of problems that we've managed to work through. I think it's a good time to reflect and thank our staff and our partners for all the hard work and support that we've had over the last year. So hopefully this evening captures just some of the work that we've been doing during the pandemic. And whilst it's been really difficult and we've had people, isolating at home, we've had lockdowns, it'll give you a sense of that we've had all that to deal with, but actually the hospital has carried on doing the very good work that it does so well. Next slide, please. So a couple of quick stats about what we saw last year in terms of activity. You will notice that we saw 91,000 or 92,000 patients through our ED, and that was really because of the lockdown measures. Normally we would expect to see about 120,000 people. You'll see that we still managed to do a lot of elective surgery for planned admissions, and you'll see that we still managed to deliver just under 4,500 births. So although we did have lockdowns, we had the pandemic, the hospital was still really, really busy. In terms of our patients, we saw about 350,000 people last year, but we did all of that virtually. So what the NHS did and what we did here was introduced technology in a way that we've not done before, and we've made quite a lot of advancements, and that they've been quite successful. We're learning all the time, and it's a lot of new and different ways of working that we will continue to take forward and develop and refine where we need to. Next slide, please. So our year, I think one of the most important things really is the National Staff Survey, and this was effectively undertaken in a COVID year. So our staff still ranked us the best nationally, and that's something that we should be really proud of, particularly when people look forward to coming to work, and that's a marvellous achievement really, isn't it? Particularly of some of the difficult pressures that people were under during the course of the last year or so. We were the 4th best acute trust in the country when asked if staff would recommend us as a place to work, and that's a big tribute. Financially, we ended 2021 with a small surplus of £47,000, and Paul Simpson will talk you through that later. Next slide. So we've launched a new mental health strategy, and we've embarked on an integrated care improvement. We've had a lot of very successful working groups with our partners at Surrey Borders to develop really a clinical model which we hope going forward, providing we can obtain the funding in the capital, we think the clinical model will deliver the very best care and get the very best outcomes for our citizens who suffer with mental health issues and illnesses. But we'll tell you more about that as the current year goes on. We've done a lot of work with our nursing associates, and our chief nurse will talk about that later. So we're very pleased that we have a very vibrant programme really to add to the things that we do around training and education and development. And we're trying to make it a very vibrant place to attract staff to work and come and spend their careers here. So we completed our first operation using robotic surgery. That's really moved us well into the 21st century now. You'll see a very delighted team of surgeons and nurses and theatre staff on the right-hand side. We're starting to use robotic surgery now for almost everyday surgery. When robotic surgery was initially introduced, it was introduced more for complex cancer surgery. So we're developing that level of expertise here at SASH. And what will it mean for the patients? So it should mean that the procedures can often be slightly quicker, more precise, and we hope that that will give patients a better recovery with a shorter length of stay and a better outcome. We've also introduced new equipment measures, particularly around our diagnostic tools that we're using for what we call vital signs. So they're the sort of small computers that measure things like blood pressure and heart rate at the patient's bedside. So making it very easy for the clinical staff to record accurately those vital signs that we need to monitor while patients are unwell with us here in the hospital. Next slide. So quality of care, you'll see a few highlights there. So falls, particularly in our elderly population, remain under the national average. Our mortality rate is lower than expected. Our outcomes are in fact very good. And one of the top performers in the country for some of the constitutional standards, particularly waiting times within the A&E department. And our safety goals that we've developed for each division are really becoming quite embedded now, because safety is one of the most important things for us here at SASH, because we know that actually if we're in charge of safety, we do that well, we will get better outcomes, patients will have a better experience, and hopefully they'll have a very shorter stay with us. So the year began during the first peak. We had incredible support from all our community partners and from our local community, particularly other places like Gatwick Airport. We were really privileged really to be provided with huge amounts of things from food and drinks and a whole range of things to support the staff, and I know that they all valued those. And thank you to everybody who helped with that. So unfortunately, you know, it's a time when we have to reflect and remember some of our colleagues who lost their lives here at SASH to the virus, particularly in the early stages. Many people have lost friends and colleagues and family members, and I thought just a moment to reflect really on how difficult the pandemic has been, particularly in the early stages. So COVID-19, so we keep transforming our infrastructure to cope with demand. We increased at the last peak, which is last December, last January, our critical care capacity by about 300%. We were very fortunate really to have the British Army here to help us. At different times we had 60 soldiers who provided us with a range of support across the hospital, from helping us do portering duties, catering duties, helping us turn patients, complex patients in intensive care. The Royal Engineers helped us with some of our pipe work and a whole range of things. We really couldn't have got through without them, and we will, I know, forever be grateful to them. So our whole wards and departments were revamped overnight, and big thank you to our estates team. We did a lot of very crucial works actually at different times, and that was important because we had to change the way the hospital operated almost overnight into what we call green and red areas. So we needed to keep green areas as COVID free as we possibly could, so that we could continue to undertake some form of time critical surgery, particularly for cancer and for some of our emergency patients. So a big thank you to all those involved with that. And many staff worked in unfamiliar roles in different locations. So one of the things about the NHS is it is very, very versatile. The staff are very committed to do things differently, and people found themselves operating in different environments. Indeed, many people volunteered. We had 260 staff who were redeployed, mostly to critical care, but to many of those at the hospital as well. And then I talked about our Army colleagues who worked tirelessly to do a whole range of things, as I've already said, but particularly to help arrange appointments and to provide new ways of providing care. They're the hidden heroes really, and again, we couldn't have done without them. So working through, this is one of the quotes from our porters, who, you know, fantastic team that we have here at SASH. So working through the pandemic has been tough and had an impact on our well-being, but we pulled together as a team and supported each other to get through it. I think it's really nice, you know, for our portering staff, who were amazing actually. We do pride ourselves here about being one team, and that really did actually shine through during the whole pandemic. So our colleagues in procurement, and they're often people who work in the background, but actually they work tirelessly to make sure that we had the kit, the equipment, the stocks, the supplies that we needed to keep going. We developed new unique processes to a range of things. That picture you see there was one of our operating theatres that we didn't use because we obviously did less elective work at the time, and we used that operating environment, which was a sterile environment, to draw up or the staff to make antibiotics for all the patients on intensive care and on the wards, which was time saving for the clinical staff on the wards. And it was a really nice initiative actually, and you know, something we should thank our pharmacy colleagues for, because it's something that was quite unique. So we've helped to design and implement processes to support supply to decontamination of PPE. There's a whole range of things around that we had to be very innovative to do. So for example, you know, when you had to decontaminate some of these things. It is quite specialised, so we had to use things like UV lights. We had to just bring in a whole range of different equipment that we've never used before and learn how to use it. So suspending change from motorised bases, a bit like disco balls, just to dry the PPE, because we needed to reuse some of that. And very, very innovative things, and it just shows you really, doesn't it, how using our improvement methodology through the work that we do through our SASH Plus, which is work that we've done for many years now with BMI in the US, has helped us develop a mindset really with a set of tools and techniques to think very differently about how we can innovate. And that really, saved time, protected staff and protected patients by providing the right equipment at the right time in the right place. So we saw extraordinary demand on our services. We talked about that. June 2020, 1,000 people with COVID had been cared for at the hospital, particularly the first peak. And then during the summer, we enabled each patient to have a visitor once a day. We still have those restrictions in place, but we've opened up visiting, particularly for vulnerable groups, so patients with dementia, those patients, unfortunately, who are on the end of life pathway, and patients with learning disabilities. And we should keep those restrictions in place really till we're a bit clearer, a bit more certain about how the relaxation of the recent lockdown rules goes, and we need to understand and monitor the effect of that. So really getting, patients were isolated, particularly during the peak periods of the pandemic, and the IT staff here worked with the clinical staff to be quite innovative, so that we could put things in place like iPads and a new digital framework, so that people would actually talk to their relatives and their loved ones. Something we've not really done in the NHS before. It's now commonplace. So innovation really does spread, and I think what it shows is we do have the ability to adopt it and implement it very, very quickly. So it meant that people could have video calls. It meant that people and vulnerable groups of patients didn't feel isolated and alone, and it actually maintained relationships with concerned and worried relatives as well. So the vaccine really brought much hope during the winter period. You'll see the figures there. So just over 9,000 doses of vaccine were given to all our healthcare professionals at SASH in the early days. And we, on top of the pandemic, on top of seeing the normal emergencies, on top of doing our time critical cancer work and all the other things that we do here, including delivering babies, the staff pulled together to roll out the vaccine programme. And when you look back, it is actually quite astonishing. So our Chief of Medicine, Dr. Mears, would say, so the pandemic has been both exhausting and inspiring. We're so grateful to the local community and to the Army for all the support that they have given us during an incredibly busy time. And I think that kind of sums up about what we all feel really, particularly when we look back and reflect just what we've achieved and how busy we've been. So the vaccine programme coincided with the second largest peak, excuse me, and with well over 200 patients with a positive test resulting needing to be admitted to the hospital, it was really, really difficult. We're incredibly grateful to support, particularly as I've already said, to the armed forces who provided this variety of roles that we had to support us delivering the frontline care that we needed to provide to keep our patients safe. And we saw extraordinary demand on services and helped thousands of people recover from serious illness. Interesting, isn't it, that just over 2,000 people recovered enough to be discharged, having been an inpatient with COVID-19. And our first patient you'll see there was 100 years old to recover from COVID, and we were all very proud of that at the time. So thank you. We're hugely grateful for all the support that we've had. It's been an incredible year. We look forward to working with all of you for the rest of this year and into next year. Supporting staff has been one of our top priorities. We've made significant investments in a whole range of things. It's something that I didn't think the NHS would actually ever have to do, but particularly psychological support to complement some of the existing things that we put in place. It's true that the pandemic has had a significant effect on many of our clinical staff, and they have required either counselling or some form of psychological support. We've had huge amounts of support from our chaplaincy and from the different partners in our community, and that just, I think, reminds us really of how devastating and traumatic the pandemic has been on some of the lives of our clinical teams. And then support through our charity, SASH charity. You will have heard about that. We've had some amazing contributions really from local businesses, local organisations, to other charities, to Captain Tom, a whole range of things that we've been able to put in place to actually make the lives of our staff a little bit more pleasant in what has been a difficult time. We've had to put in new and different things. You'll see some examples there of pods. One of the things we've had to try and do is create space, particularly for social distancing, so that people can have some time out, some time to reflect, and even time to take meal breaks. So you'll see all those things. We've managed to do some, do things at Crawley, at Horsham, and at Catering Dean. We've managed to do a whole range of things, whether it's thank you boxes for staff or new computers, and as much as we can really to actually make it better for everybody. And that's all I have to say. So thank you for listening.
Thank you very much, Michael. So now we're going to turn to Ed Chetty and Jane Dixon, who is remote.
Thank you, Chairman. So I'm Ed Chetty, Medical Director, and I have the great pleasure of introducing the short video that the Chairman trailed earlier on. In this video, you'll see various members of staff talking about their experiences working here during the pandemic. Throughout the pandemic, I never ceased to be inspired by how our staff rose to unique challenges. Michael's already talked about how staff were redeployed to work in different areas or changed the way they worked to respond to what was really challenging period. Doctors and nurses, yes, but also staff for all different disciplines and grades. Allied health professionals, pharmacists, porters, caterers, housekeepers, procurement, administrative staff, they all played their role and never lost their focus on the safety and quality of care for our patients. So we're very proud of how our staff stood up in these circumstances. And I'm really grateful for Jamie and his team in comms for putting this video together, allowing them to talk to you today. You'll see that not all staff groups are represented here. Some people didn't feel able to talk about their experiences yet, particularly some of our doctors. Maybe in time they will. The video gives you a real flavour to what our staff went through. So I'm going to hand over to Jamie now, and please run the video.
So during the pandemic, I was lucky enough to work with a team of nurses in an IV reconstitution unit set up in the district theatre. During this time, I really felt the one team attitude of the hospital, as we were all working in an unknown area. We like to call ourselves 21st century bomb girls, and it was a really exciting opportunity. It was great to see pharmacy lead that.
Working through COVID-19 has indeed been quite a challenging time for all of us across the globe, including here in East Surrey Hospital. So whilst working in East Surrey Hospital amongst different teams and colleagues, I have experienced unity in diversity in providing care for these patients, witnessing relentless times of inspiration provided by the administration, seniors and allied healthcare professionals to care for these patients, while adding a little bit of fun to an otherwise hectic schedule, has inspired all of us to work as one team towards helping sustain patient well-being and health.
So during the COVID-19 sort of pandemic, I feel like as the pharmacy department, we had to really become very adaptable to some very fast-paced, changing environment. We had to sort of adapt in terms of infection control procedures, the way we work on the wards and ward moves, so we have to support the ward teams to make sure that medications are being administered safely, but in a new sort of novel way of working with infection control procedures. Not only that, we as a team were very resilient. I think when people were isolating or we were short-staffed during the initial periods of the pandemic, we still managed to sort of provide safe patient care.
The experience has been challenging, certainly from when it first happened in 2020. We very quickly had to adjust to what life was like in the procurement landscape. It was very difficult with our supply chains and what we could get in and what we couldn't get in. We have worked every weekend. We've been in 7 days a week, but we wanted to help our clinical frontline staff as much as we possibly could in any way that we could.
And we didn't run out of any PPE. And that makes us, I think we both feel really proud that we managed to achieve that and that our team has managed to achieve that for the Trust.
During the COVID pandemic, the focus of our work has been on looking after patients whose COVID symptoms are so bad that they're struggling to breathe. We are able to use high-flow oxygen devices to support their breathing. However, we've also had to take a lot of patients to intensive care for further support and treatment. Seeing the fear in someone's eyes that is struggling to breathe due to coronavirus and then telling them that you're going to have to take them to ICU is something I will never ever forget. On a positive note, seeing patients who have been really unwell but have survived COVID and ICU and are now ready to rehabilitate and to go home to their families is the most satisfying feeling ever and makes everything worthwhile.
Last year, working during the pandemic situation, I think what happened is we were all in the same boat. We were not sure what was going on. But what was really nice and interesting is working as one team. We all help each other. When I say help, I'm not saying not just the patient, but even colleagues and anyone that can work together to be able to deliver the service, go the extra miles to help and support each other. And it was an absolute privilege, but it's still now an absolute privilege to be able to fight for others.
During the whole time of pandemic period, we had a restaurant open. We never stopped our services. We knew it. Our services is very important for medical, non-medical staff.
During the pandemic, we have realized how important it is to be together and to talk to each other. We spoke with everybody, with doctors, with nurses. We always make sure that we ask how they are and we share a laugh. We always make sure that we welcome everybody with a smile and open arms to make sure that everybody's feeling good in our restaurant.
We didn't only become a family for our team or our colleague. We also, I have seen example of nurses become family to the patient who are dying. Because at the time, people were dying without their own and the loved one, and we were the one who were holding their hands.
Yeah. That was difficult for staff as well, but a lot of them on reflection have actually felt really honoured that they were with them at the time. So, overwhelming is certainly a word, but actually looking back and reflecting on it, there's a lot of pride with that now, and how the ward handled it, how all of our colleagues handled it.
Hi, my name is Raim. I am from Brazil. I am a ward hostess for Live Ward. Well, at the very beginning of the pandemic, it felt surreal what's going on, and it was a very difficult time to deal with. I was very worried and I felt scared to go inside the ward, but you build up the courage with time. But speaking to my ward colleagues definitely helped a lot. We felt united and we knew together we could beat COVID. It was very nice to see I belong not just to a team, but to a family.
We launched a safe and rapid quality COVID testing service from scratch, which operates 24/7.
One of the biggest challenges we faced was due to the national reagent allocation, trying to fit 30 tests a day in for a 600-bed hospital. been a year like no other. I planned for emergencies in my day job, but no one could plan for COVID. There are no words to describe the roller coaster that was 2020. Last year was definitely an experience, to say the least. And I remember when myself and Amisha, who's my pharmacist, we were on Tilgate. We were rotated to be on Tilgate during the COVID outbreak, and we had, I remember the day actually, we had our first COVID patient admitted, and just the feeling on the ward, like the atmosphere was just insane. Like we were all terrified of it, and it was just the thing that I found quite comforting was that everyone was in the same boat with it.
So I work for the hospital charity, and we decided very early on to focus on supporting staff welfare and urgent requests from members of staff. We were able to, thanks to some extraordinary support from our local community, we were able to fund things like tablet computers for every ward at SASH, so that family members of people with or without coronavirus could do video calls with them right the way through when visiting was restricted, all the way through to really meaningful things like supporting psychological interventions with staff and workshops for people who have been going through this very difficult and at times traumatic period.
I mean, personally for me, it only dawned on me that it was going to be, how bad it was going to get, when I remember stepping onto HDU, which is normally our level 2 patients, and then suddenly it was full of ventilated patients. And then every time we sort of went into the next area,
created a new ICU on another medical ward.
It was kind of those sort of times which, when I think back, really stick out in my head. I can still remember walking into HDU and being, although we knew it was coming, still being quite shocked.
So at the start of the pandemic, Chris and I thought about what we could do to make sure that the patients that we would normally be involved in, we didn't miss. And so we started doing daily ward rounds, where we would go to every ward every day and check in with the nurse in charge and the staff there. Do you have any patients that have a learning disability? Any patients with dementia? Any safeguarding concerns?
And so I make a point of checking where the patients with dementia are, phoning into families and just checking with them and giving them some updates on how their loved ones are, and sort of giving that sense of assurance that we are aware of their dementia, aware of their other needs that they may have, and just kind of continuing that support that we would have provided if they were on site.
My first day here at SASH was the first day of our response to this pandemic. To say my experience has been a whirlwind could be an understatement. I was inspired mostly by the energy of all staff here when we needed to react. Without hesitation, all staff rose to the challenge.
Since patients could stay, had to stay at home during lockdowns, we had to innovate. And whilst in the past we would have thought it was impossible to treat patients from home, we were now forced to think about how we could help these patients from home. And I discovered that actually seeing patients by video and being trained to do video clinics by senior clinicians, we can actually pick up a lot of information. So, and what I've basically discovered since COVID is that there are lots of things that can be regarded as positive. We've tried to step back, think about conventional ways of working, think about how we could make it better, and in fact we found so many better ways of working that they are here to stay.
I think for me, one of the things I've realised is how much I value being at work, and I feel very lucky and blessed to have been at work throughout this period. But I just realised I need the social interaction, I've needed that challenge, and just to be able to intellectually use my abilities, to feel like I'm contributing in a small way.
So working through the COVID pandemic for haematology was very much keeping our immunosuppressed patients safe, carrying on with as much treatment as we could, relieving their anxieties.
Our pandemic was slightly different, and what I wanted to say is a huge thank you to the chemotherapy team. For us, our goal was to keep our patients safe, and so we moved to a cold site very early on in the pandemic. So the first weekend in April, the chemo suite moved, and then in May, Comet moved. We were there for a year, The team were phenomenal, and I was humbled by the experience and watching them work together hands on.
Being able to offer them their listening ear, offering the prayers for the ED and ITU nurses before they start their shifts, 7 o'clock in the morning and 7 o'clock at night. And I could see staff who were finishing their shift and they could just burst in tears. And I was there with them and chatting with them. Or sometimes when the staff go for the break, you could see they're just exhausted or they are so upset for feeling hopeless. And I've seen that most of the staff and chatted with them. And one of the key things that my department did is to offer the staff support. So we were so keen to offer that staff support, and we are continuing now. We are still offering meditation now, and we have started offering bereavement support. Going through that, I've seen more deaths, as more than I have ever seen in my 15 years as hospital chaplain.
And I think our role therapists, not just in ICU but across the hospital, that we can often spend a lot of time with patients, like sitting with them, talking to them, which doctors and nurses don't always have that time available. And then to have visitors not be allowed in, which was so hard for the patients, that actually we were taking on a huge role with just comforting patients and trying to facilitate them being able to talk to families.
So on ICU we quadrupled our capacity from 4 full-time physios to 16 full-time physios working 12 hours a day, 7 days a week, and most of that was to support sort of nursing staff, to help with proning. We were sort of helping with washes, we were sort of taking the less clinical bits off the nurses that we could do just to help support them, as well as chest clearance and our rehab that we would have normally done. I mean, we obviously work closely with ICU nurses. I guess my admiration for what the ICU nurses went through, and seeing them, you know,
so much pressure was put
on them, and
teams,
and they were just phenomenal. Like, I don't know how they did it.
Dived headfirst into helping both non-clinical and clinical teams around the challenges that they face with COVID, and especially around processes. One particular area that I focused on was patient property. So what we did is we actually managed to employ an extra porter who was just dedicated, you could say like a postman for example, who was just solely there to deliver patient property. So something that would take a really long time to deliver actually managed to be 10-15 minutes maximum, which was amazing for our patients.
Support from the trust was absolutely marvelous, right from the cleaners who has constantly keep us on the clean side, and also from the support from psychologists and like Chisholm.
Our duty of care became so frontline for everything, and everybody was honestly, I cannot say everybody was just amazing.
Exhaustion. Shocking.
Challenging.
Heartbreaking.
Emotional.
Surreal.
Humble.
Draining.
Commendable.
Family.
Brave.
Inspiring.
One team.
One word describing my colleagues, they're phenomenal.
Thank you. It's Jane Dixon here. So I said that I would close after this piece. Can you all hear me? Yes. So, well, what can really anyone say when you've watched something like that? It's difficult to know what you could say that would play justice really powerful narrative. What we heard Michael describe at the beginning, we've now heard again through the very real voices of those people that actually did the work, delivered that care and undertook those roles. What I find so powerful about this, as Ed said in his introduction, this piece really demonstrates the diversity of our workforce and the different roles that people undertake. We often talk about doctors, nurses, pharmacists, physiotherapists, but actually what we saw demonstrated here is the significant number of people who whose voices are often unheard, maybe they're unseen, but actually they played such a significant part in everything we did in terms of responding to the pandemic. And I know that I speak on behalf of all of us when I say that we couldn't really be prouder. I think it's also important that there is a historical narrative and historical records about the pandemic, both written and verbal. And I think pieces such as this need to form part of that historical record. I think it's also really important that we continue to support our teams. We know that we continue to innovate and develop our services to enable them to be best placed to continue to respond as we move forward. I think what we saw demonstrated in that video was the values that we work to as a team and as a hospital. And I would like to reiterate what was said at the beginning by Richard and others. Our condolences really go to those that lost their lives, those that lost loved ones, and our huge thanks to our staff members across the whole hospital who delivered and continue to deliver such outstanding care at such times of such pressure. Thank you for those who participated in the video. And also we know there are many other narratives we have that we could share, both written and verbal, and they will be available for people to see. Huge thank you.
So thank you, Jane, and thank you to everybody in that video, which was moving and humbling and professional and supportive all together. Thank you very much for that. So now we're going to change gear a little bit, and Paul Phillipson, our Chief Finance Officer, is going to give us a quick overview of our annual accounts.
Difficult to follow that video. But we also had to manage the money as we went through the year as well. We also had to do it in such a way so that all the people that you saw in that video actually had the resources that they needed to do what they needed to do. And I think we managed that pretty well. The auditors checked us out at the end of the year and they've given us a nice clean bill of health. So we took the annual accounts to the audit committee in June, and PricewaterhouseCoopers gave us an unqualified external audit opinion on the 15th of June. There were no material issues in the accounts. As Michael said earlier, we delivered a £47,000 surplus. It's a very small surplus, is effectively a break even. And just for those of you that are going to have a look in the accounts, and you will see that there's a different number in the accounts, just to explain a little bit about what that is. So the £47,000 is a NHS performance value. The technical items that are adjustments are impairments and a few other things in respect of donated assets. An impairment is when a building is valued at a lower amount than it costs to actually build, and so we have had some of those, but those actually don't count against the NHS income and expenditure position, which is a small surplus. There's a little table down there at the bottom which, if you can read it, explains what that variance actually is. It was a very different year financially because COVID meant that the centre abandoned all of the normal processes, the planning processes, working with CCGs, because that wouldn't have been an appropriate way to manage the pandemic. And we had something called the COVID finance regime. That meant that we were paid with something called a block contract, which was topped up with extra payments so that we could meet all of the financial needs of NHS trusts as we went through the year. It shifted halfway through the year for various reasons, and the trust managed that, I think, very, very well indeed. And we had an expectation of delivering a break-even position. That's what NHS England expected us to do, and that's what we did deliver. So that was a fantastic job, and that's by everybody in the trust as well, still paying attention to the money while we were doing everything else. Next slide, please. A new thing in the account this year, so on top of COVID, we had an extra thing to do for the auditors, and it's called the Auditors Annual Report. And this is an expansion of their work on value for money. It's something that was asked for by the National Audit Office. And they gave us a report which looked into all of these things, our financial sustainability, our governance, and how we were improving economy efficiency and effectiveness, basically how we're making savings and things like that. It seems like an underwhelming comment, but it's a good output from this as well. PwC found no significant weaknesses in any of those things. And there's a detailed report, we talked about it at our board, and we'll be publishing the whole thing on our website for you to read, should you want to do so. SASH remains a low-cost trust, and this is a slide I show every year. I've got a couple more things to add to it. We have the 5th lowest cost per weighted activity unit of any trust, any acute trust in England. That's not as good as last year when we were 2nd, but that describes the kind of organisation that we are at the moment. The actual value for cost per weighted activity unit went up a little bit compared to what it was in 2018-19, and these figures are a year out of date. So these aren't for 2021, these are for 2019-20, because that's the way the process works. COVID actually hit in the last few weeks of March of the 2019-20 year, and that's one of the reasons why the figure is a little bit higher than it was in the previous year, because we simply didn't do the amount of activity that we would normally do for those 3 weeks of the year. That gives you some indication of how much activity, how much work the trust actually does. This weird graph, also from the model hospital, shows us, so these are the 4 other trusts that did better than us in terms of their costs. I won't name them, but you can read them on the chart. And you can see that we're up there in the top left-hand quadrant of this chart, which combines CQC ratings. If you're a dark green, it's outstanding. Green, it's good. If you are requires improvement, you are red. So you can see where we are, and it tries to show all of these things on the whole chart. That's how we compare with other acute trusts across the country. So we are a low-cost, high-quality trust. Last year also saw us spend more money than we have ever spent on capital, on our infrastructure spend. So we spent £22.2 million. Again, there's a technical adjustment because donated assets are removed from that. So actually there's another nearly £1 million there. We actually spent £23.1 million on our infrastructure. That includes donations, what's called donations from the Department of Health as well. But we should also thank the League of Friends as well, who also contributed to equipment during the COVID year, and we mustn't forget that. The biggest area of spend here was we spent nearly £5 million on our digital infrastructure. So that's our electronic patient record in SASH. That included our electronic prescribing and medicines administration system. So again, while we were going through the COVID year, we were still investing in the systems that we need to make the trust work really well. We also discovered a few things that didn't work properly. In the first wave, we had problems with oxygen within the hospital, and that's partly because we've only got one of something called a VIE, a vacuum insulated evaporator, which provides the oxygen. But we also didn't have an adequate ring main, if you like, that circulated the oxygen across the trust. So we were awarded an extra £1.7 million to install a second VIE and create a proper ring main piping system, which has resolved the oxygen issues that we had. So we are now well and truly properly sorted in respect to that. We also bought a lot of equipment, especially for managing COVID, and we claim we were paid £1.7 million by the Department of Health in respect to those capital purchases as well as receiving substantial amounts of PPE and other equipment, which was paid for by the Department of Health and Social Care. Finally, just to say that our financial plan for 2021-22, COVID is still with us and normal NHS financial processes remain halted. So again, in 21-22, our intention is to deliver break even against that, and we'll just use our cash reserves to finance the remaining loan repayments that we've got. And just also to say that we're working with the integrated care systems around us. There are 2 which we are in, Surrey Heartlands and Sussex. Because one of the key things we now need to do as we hopefully emerge properly from COVID is to deal with that elective backlog. So a significant part of our financial planning is to provide the financial support that we can do those elective services and to manage the winter. We expect the winter to be a tough winter this year. Thank you.
Thank you very much, Paul. And now to the last of our short presentations. from Tony Newman-Sanders, our Chief of Cancer and Diagnostics, about some of the positive things that we've been able to invest in during this difficult year. Tony.
Thanks very much, Chair. Maybe just for those who aren't completely familiar, just a bit of an overview about what diagnostics is. Diagnostics answers that most fundamental of questions that patients have, which is, what is wrong with me, doctor? It traditionally rests on 5 pillars: radiology or diagnostic imaging, and that's my field, x-rays, scans and so forth; pathology, which is the laboratory tests; endoscopy, colonoscopies, gastroscopies, looking at the inside of you with flexible tubes; and physiological measurement, which is increasingly important in the post-COVID era because it measures things like how well you're breathing, but also things like how active whether your nerves are working, how effective your heart is, and so on. And the last one is genomics, which is obviously a hugely important thing going forward, which actually gets into the detail of why we become ill and what treatments will work. When I started as a radiologist, as a diagnostician, our role was to kind of sit forgotten in a badly lit annex of the hospital, looking at the occasional x-ray and watching my other kinds of doctors get all the limelight. But as our tests got more and more sophisticated, and we found that more and more other doctors couldn't actually do without us, and diagnostics has become pleasingly an increasingly important part of the way that medicine is done. And this is recognised last year by a review by Professor Sir Mike Richards on how diagnostics should be set up. And clearly, as with much of the healthcare system, diagnostics was very challenged by COVID, and the way we had to deliver the service had to be significantly rethought through. Among the things that are happening is that, for example, rather than each hospital just having a standalone x-ray department, bigger, more joined up and more technologically enabled networks being set up to provide imaging across wider networks. There's 4 in the southeast region. Similarly, with pathology networks, it's been realised that pathology is often better delivered through bigger, more centralised laboratories, while making sure that patients can still access tests close to where they are. And similarly, approaches is being wheeled out for endoscopy and physiological measurement, although in early stages at this moment. There's been significant investment in imaging equipment, and I'll come to how that's affected us at SASH in a while. A huge amount of investment in technology, particularly digital, and how we move from paper to computerized systems. And most excitingly, increasingly, artificial intelligence is being very widely deployed in diagnostics to make the life of people like me easier and more effective. And workforce developments are including things like a new imaging academy, which is being set up across the whole southeast region to revolutionise the way we train diagnostic professionals. Next slide, please. So rolling back to before all this, when I started, one of the first discussions I had with Michael was about MRI and how we were to take the MRI service here into the 21st century. MRI is an extremely powerful diagnostic tool, and we use more and more of it. It doesn't use x-rays. It delivers exquisite images of things which hitherto could only be acquired by operating on someone. And last year we launched a brand new purpose-built unit in partnership with InHealth, containing 2 state-of-the-art scanners, a room for a 3rd one, and much better access for local patients, and delivering the highest possible quality MR images. It's also enabled us to do things which we've not been able to do, such as provide a better service for sedated patients, general anaesthetic patients needing a general anaesthetic, and paediatric patients, as well as doing more cardiac MR, which is one of the big ways in which treatment of heart disease is being advanced. Next slide, please. At the same time, we've managed to replace 2 of our CT scanners. This was done in conjunction with a big funding initiative from government to replace all scanners over 10 years old, but there's a lot more to putting in a CT scanner than just taking delivery of the check, and a huge amount of work and investment from the trust and work from the Estates and Facilities team meant that we could get these things up and running in the teeth of the pandemic. In line with national policy, because people became alarmed at coming into hot sites or red sites, COVID sites for diagnostics, we tried to do as much diagnostics as possible on our cold sites. So we increased our capacity at Crawley, and we've managed to increase capacity across the organisation, but particularly our ability to deliver diagnostics in cold sites, so that we can concentrate our technology at East Surrey Hospital on looking after our acutely ill patients. Next slide, please. And then this, not maybe quite as glamorous, but the DEXA scanner is extremely important for a very common and significant cause of health problems, which is osteoporosis and other bone-related diseases. It's extremely valuable in detecting early things which may later cause people to fall and fracture their spine or their hip. We were badly in need of a new scanner, and with the help of the Friends, the charity, we managed to purchase a brand new one, much more comfortable for patients and a much better scanner. And looking forward, as we move hopefully beyond the pandemic and as we move into a different way of working in the health service, Michael and Richard have alluded to the way we are increasingly working with primary care colleagues. We're also thinking completely differently about the way that we set up diagnostic services, to a certain extent wanting to increase access to GPs and ultimately to patients themselves, so that these very powerful tools can be made directly accessible in a timely way, and in a way which actually works much better for patients, who can get all their diagnostic tests done at one session, and then have the results of those diagnostic tests fed back in an understandable way to the doctors looking after them. It's designed to improve diagnostics across the board, but the immediate beneficiaries are going to be cancer patients, and particularly patients with cancer where you're not quite sure, you're worried about cancer, but you're not quite sure where it might be coming from. And particularly to protect diagnostics, which tends to get forgotten when the going gets rough. So things like diagnostics as a precursor to hip and knee replacements and so on will be much more resilient in the future because of the establishment of these systems. And we're focusing particularly on making sure that patients who maybe don't even know how to access tests, forgotten patients with who do not like to engage with the health system, people with disabilities, for protected characteristics, to get these tests and to get them closer to where they are and allowing them easier access to the right test first time.
Thank you very much, Tony. And that brings us to questions. We've got about half an hour or so for questions, if you can take that up. So the first question, so do get writing your questions if you haven't written them already, and post them in the chat box so that we can, between us, respond to them. So the first question is, are you going to get an immersive simulation system like the one at Ashford St Peters? Who's able to answer that one?
While it's thinking about it, I could take a while. I don't know exactly to what system you refer, but I think there are systems using virtual reality and simulation which can be described as immersive, and if that's the kind of system you've got, and at the moment we don't have that. I don't think at the moment, Ed. But these are, as that technology becomes cheaper, and certainly from my point of view, there are companies who are able to, for example, build 3D virtual realities of the inside of bodies based on CT scans. So these systems will become more easy to come by, but I don't think we have any at the moment.
No, we have a extensive simulation suite downstairs here in the postgraduate centre where we provide simulation training for all aspects of clinical care. But we'll certainly explore how to use better technology to advance that over the coming years.
Thank you. So the next question is, how did you manage to get the armed forces to help in the hospital? Did the trust approach them? And how long did they support staff in the trust? Michael.
Thanks. So the armed forces were here for about 6 to 8 weeks. We had about 60 soldiers in 2 different tranches. How do we get them? Basically, the military were assigned to those areas across the country who were most under pressure. And although we talk about this very calmly, during the last peak over December and January, our hospital was one of the most pressured in the country. So when we talk about quadrupling our intensive care beds across the board. We have 16 critical care beds, so we had to quadruple those in a range of different locations and redeploy staff, which meant that we didn't have some staff for normal duties. We also did transfer 80 patients out at the same time by road and air to different parts of the country, the furthest being Newcastle and down to Cornwall and Devon. So we were considered to be under pressure, and that was really around the prevalence of coronavirus, particularly in Crawley and in some of our more deprived areas of Chandridge and Mole Valley and Redhill. So effectively, it was an easy conversation to have. The ministry were very keen to help. We cut through the red tape, and we were very successful in getting the armed forces here at SASH for that length of time. And again, a big thank you to all of them.
So I can't see any other questions up there at the moment. But while you're thinking of questions, maybe I can ask Jane a question, because following that very moving video with the contributions from staff have clearly been through a lot, and they would have been anxious also about their families, especially perhaps those who've come to work with us here from other countries and who've not been able to visit their families for perhaps a year or 2 years. So I wonder if you could just comment, Jane, on how our staff emotionally have been coping with this last year.
Thank you, Richard. It's a really valid question, and one that we've talked about a lot around health and well-being, ongoing support for staff. And we saw some of that described in the video, as you say. We saw our chaplain talk about the work they've done to support colleagues. We've got an inclusion network, we've got buddy systems, we've got executive teams that are out in the Gemba, seeing people, talking to them, listening to them. So we're trying to do everything we possibly can to respond to individual concerns and concerns collectively. But there is no doubt that being far away from those that you love at a time like this is particularly challenging. We've all been far away from our families, but if you're very, very far away and you see news about distant parts of the world, we understand that's particularly challenging. So we are continuing to listen to and try to act on anything in addition that we can do. And examples of this will be that when we see news coming from across the globe, which tells us about particularly difficult times in parts of the world, we will often try to bring focus groups of colleagues together for them to tell us specifically what more could we do, rather than the assumption that we know what we can do. And they will sometimes tell us interesting things that we haven't thought of, and therefore we respond to that. But I think the important thing for us to do is to acknowledge that everyone's going through difficult times in different ways. People's experiences are different, and therefore we need to be listening and responding to that in real time.
Yeah. Thank you. A number of questions have now come through. So the next question is, when will we know about how much funding will be available for the mental health service development, and what type of staff roles and vacancies will the service create?
Do you want to have funding model?
So I'm assuming that this is talking about the potential Surrey and Borders mental health unit that we're talking about putting on to the East Surrey Hospital site. Funding's a difficult one at the moment. So NHS England and the Department of Health and Social Care are putting in place new regulations around capital. And although Surrey and Borders Partnership, for example, have significant cash reserves as they've made land sales previously to cover the costs of these sort of buildings, it's really difficult for them to access that because of the way in which capital spend is controlled and managed across the NHS at the moment. So it may be that we're not able to properly access that cash, and we're currently looking at how we might try and secure the funding, or the capital resource limit and the funding that is already with Surrey and Borders Partnership through one of the allocation routes that the government are currently operating. So that's the new hospital development scheme and so forth. So we're trying to explore those currently to try and free up the funding that might allow us to proceed. If we do proceed, I'll just go on and answer the rest of it a bit. It's quite a significant mental health unit. The idea, what Surrey and Borders Partnership are doing, they're putting units geographically around Surrey, and citing one here would help to complement our services. I can't say exactly what the staffing will be, but it will be a significant number of staff dealing with those particular services for this part of the geography.
Okay, so more later on that. Next is about visiting. So have we changed any requirements about visiting the hospital since the 19th of June? And Jane, would you like to answer that one?
Thank you. We're constantly looking at the national guidance. We're constantly looking at details and data around infection rates locally. And what we have done is continue to enable one visitor to attend every patient, every inpatient for 1 hour a day consistently, providing they're asymptomatic and they undertake lateral flow testing. Apart from our surgical pathways where we know patients are coming in electively and they plan their care, but also for paediatrics and maternity, there are different visiting arrangements. People have always been able to be with their children and have birthing partners too. So we've continued with one visitor a day, because we think it's really important that we reduce the footfall and we enable visiting to continue longer term, rather than allow large numbers of people to come in and to see infection rates rising. We're really conscious that society has changed their rules and guidance. As a hospital, we must maintain infection control policies and procedures to keep everybody safe.
Thanks, Jane. So the next is from Les Rundle. A neighbour recently had a PET scan at Guildford. Would it be possible to use the services at the Royal Marsden at Sutton, which is much nearer and easier to get to?
So the short answer is yes. These are services, PETs, it's actually PET CT. So PET scanning is a very clever scan that looks at the way the brain's actually working in real time, and maps it to detailed anatomy, typically used for very sensitive detection of cancer. It's what's called a centrally commissioned service. So it's not a service that is typically been set up by local clinical commissioning groups or individual trusts. And there is an arrangement. So the default service for this part of the world is hosted by Guildford. We've in fact recently had discussions with the providers of PET CT scan, which unfortunately went quiet, but we're going to pursue them again to see if we could actually get them to park their next generation of scanners nearer this site. But in the short term, I'm happy to take that one offline. I don't know, Jamie, what the probably do the detail of that offline and see what's possible. But in principle, I don't see why not.
Okay, so if you're looking at talking to Les Rundle offline, is that right?
Yeah.
Then perhaps Jamie, you could give your contact details for Les too.
Of course, we will write in the chat box the best email address to send the question to. So we will publish that in the chat box shortly.
Okay, very good. Hope that's helpful, Les. So the next question is about robotic surgery, which is probably you again, Tony. How did the first robotic surgery go?
Probably Ed, actually.
Or Ed then. Is it something you'll be using more going forward?
So we're glad to say it went really well. So the trust acquired a new surgical robot recently. This allows surgeons of different specialties to do procedures in a slightly different way, or technical support through technology, quicker recovery time, less risks. And the first surgical team who've been trained on the robot, and for the first case of the urologists for kidney surgery. So the first patient went really well. In fact, they've been interviewed by the media and expressed their extreme gratitude about how well it went. Urologists are working on now moving forward with more patients, and we are training up another surgical team, and we'll do that team by team as we spread the use of this through different surgical specialties over the coming year.
Excellent. Thank you for the answer and for the question. So the next one is about artificial intelligence. How has SASH used AI? It was mentioned, but no examples were provided.
Yeah,
Tony, you mentioned it.
Apologies. I mean, there are obviously artificial intelligence in in medicine is approaching the steep part of the curve, and in fact it was approaching it about a year ago. To a certain extent, the pandemic slightly slowed it down, but one of the direct results of the pandemic was that some software, some AI systems that were pretty much ready to go were rolled out quite quickly, and the one that we're going live with, I think within the next week as part of a pilot, is artificial intelligence to help with the interpretation of CT scans in acute stroke. It's not only that it is able to see more into the images than the human eye, but it actually pulls together aspects of the imaging which enable us to take things to the next level. So without wanting to get overly complicated, what it enables us to do is change the way we do CT scans to get a very rapid impression of if there has been a stroke, not only if there has been a stroke, but how much of the brain is irreversibly damaged and how much of the brain is still viable. And this is crucial when it comes to the very rapid decision that has to be made for this new treatment called mechanical thrombectomy, which has been a complete game changer for stroke. It means that rather than a stroke effectively being a form of life sentence, that increasingly, if we act quickly enough, and this artificial intelligence helps us to do so, patients can have literally disease reversing treatment. So you can come in to the hospital with a profound weakness down one side of the body, unable to speak, and 5 hours later you can leave completely intact. So that's just one example that we're going with live now. We are about to pilot a system which can detect fractures in X-rays, which we're piloting with our advanced care practitioners in the emergency department to give them some support in their judgments. And at a sort of deeper level, we're working with partners, particularly at the Academic Health Science Network, to look at some very nearly ready to go technology which can effectively help with reporting mammograms, and particularly screening mammograms. More recently, we've just signed off to be part of a trial. We're about to sign off to be part of a trial that King's are doing, which is piloting artificial intelligence that is able to detect abnormalities on brain MRI. So there's lots going on, and this part of that question will have a lot longer answer this time next year.
Thank you, Tony. So the next is back to mental health. I understand the Trust has had more and more patients, both adults and children, with mental health problems being admitted to the hospital. Is this related to the pandemic? How are you coping? And how are you working with local mental health services?
Jane's going to play. Do you pick that up, Jane?
Thank you. I'll pick that up. Yes, we have seen an increasing demand for care for patients with mental health problems, both children, adolescents and adults, which does place increasing demand on our staff, but also for those patients. It's really important they have access to the right care when needed. And some of those patients need to be in our acute hospital because they have acute medical needs and requirements. And then we work very hard with our colleagues externally to have them transferred to the right place of care when required. There is a lack of capacity across the country, we know that, and increasing demand has really placed more pressure on that. So the kind of work we're doing with our local partners is reaching in and reaching out to each other's services. So if we cannot find a bed in the right place for a patient, then asking the services to come in and help provide care in our services for that patient. We're looking at escalation and finding beds further afield for patients to achieve and access the right care whenever needed. And of course, we're working very hard with commissioners to look at what should the services be out there, how should they be commissioned. And also, we've already spoken a little bit today about the possibility of building more beds, more capacity, really looking at mental health and physical health being seen without rules. There's a lot more we need to do about that. And we continue to work with partners really to look at what more can be done until that capacity is in place. What can we do to take the care to the patient in the right place?
Thank you, Jane. So there's a question here about reducing waiting lists. How is the Trust coping with reducing the waiting lists which have built up during COVID? How are you keeping in touch with patients, and how do you prioritise who will be seen urgently?
Yeah, I'll take that. So you're right that across the country and in this Trust, waiting lists did build up during the pandemic, but over the last period of months, we've made great progress in starting to reduce those as quickly as is possible. And the numbers of patients who've been waiting a long time have fallen significantly over recent months. We continue to work on that. Our clinical teams and booking teams are keeping in touch with patients, both to keep them updated on progress and how long their wait is likely to be, but also to get an update from the patients on whether their clinical situation has changed during their wait. And we are constantly prioritising patients on the basis of clinical urgency. So those patients who are most urgent will be done the most quickly, and if someone's clinical situation changes, that will be re-evaluated.
Thank you. So the next one touches on virtual and video appointments, which Morley Butt mentioned in the video. So virtual and video appointments significantly increased during the pandemic. Is this likely to continue as a normal way of working, and what's the impact on patients? And again?
Yeah, I'll take that. So you'll have seen in the video today, one of our orthopedic surgeons talk about how we changed the way we do outpatients very quickly during the pandemic out of necessity. And we've learned a lot from that process. We've learned that if you organise virtual or phone clinics carefully and give patients a degree of choice with a good administrative backup, it can work really well for a lot of outpatient services. Not absolutely everything, so there are some face-to-face appointments that are still necessary. Some patients will really feel the need to be seen face-to-face, but others find it much more convenient and easy to have a consultation with their clinician from home or even from work. They don't need to take time off work, and they can stay with their families, they don't have to travel to the hospital or park in the car park. So it works really well for some people, some teams, some specialties. I think it's here to stay as a hybrid model, some virtual work, some face-to-face work.
Thank you, Ali. Next question. How do you feel about the removal of the physical clinical libraries at Ashford and St Peters? Is it going to happen at SASH, as the libraries are fantastic? So I think I know what answer is being encouraged.
Yeah, thanks for that. So we've got a fantastic clinical medical library here. Well, actually, it covers a range of multi-professions with no intentions of not having one. It provides a huge range of services to all the clinical staff, and we make it as COVID secure as we possibly can, and it's here to stay.
Good. Now the next one is, we read in the papers that Michael will soon be retiring after 11 years in the hospital. When does the new chief executive start, and how will this impact the outstanding services, the trust, and reputation of the trust? So how will it impact on the outstanding services, on the trust, and the reputation of the trust? Do you want me to go, or do you want to go on that?
Well, that's one for you, Chair.
Right, so Michael is retiring later in the autumn, in November. The new chief executive will start. In fact, the new chief executive has been appointed. The new chief executive is going to be Angela Stevenson, who is currently our chief operating officer. She won the appointment against a tough field of candidates. The selection panel involved external decision makers as well, somebody from NHS England and somebody from the chief executive of another hospital in another part of the country. And she was the unanimous choice of the panel. So we're very pleased to welcome her as chief executive when Michael does step down. How will it impact on the trust and its services and its reputation? Well, Michael, we all know, has done a fantastic job here over his 11 years. I think when he joined, the hospital was not in the outstanding state that it is now. I think that's fair to say. There are a lot of challenges to be faced up to. And he has personally played an enormous part in the recovery of the hospital and getting it to where it currently is. He would be the first to say, I've heard him say it many times, that that is not just down to one person. It's down to a team effort, a collective effort, and the work of all of our staff whose professionalism and courage and dedication you saw in that film that we looked at a few moments ago. The transition is being well planned, and we are very confident that we have a strong executive leadership team, a strong board, strong clinical chiefs, and strength right through the organisation in all of the different roles that our staff carry out. So I would be very confident that this hospital will go from strength to strength. It will still face many challenges, as we have seen from the evidence today, but I think we have the strength in depth and the capacity to meet those head on, and I'm sure that its reputation will continue to grow. So that's what I'd say about that. Now the next one is Brighton, Worthing, Queen Victoria has merged into a massive trust. Are there plans as Crawley falls into Sussex? They haven't quite merged yet, but Michael.
Yeah, so I'd say that. So Queen Victoria hasn't merged. It's out for consultation at the moment, and we'll have to wait and see. Well, you know, Brighton and Worthing, you know, they're kind of on the coast really by the sea. So it would make sense for them to come together. There's no plans in the rest of Sussex to do so. I think that the good thing, if you like, or the strength, one of the strengths of this organisation and its geography is its geographical location and its catchment population. So providing the chairman does everything he's just said, then actually going forward should be really quite straightforward in terms of, you know, kind of keeping everything together and providing, you know, good, outstanding health services for that big population that we look after.
Thank you. So this might be for you also, Michael. A lot of staff who work in the satellite hospitals helped at East Surrey Hospital during COVID. Why can't they keep the fringe salary?
Yeah, well, that's the money thing. So that's the Paul thing, actually.
Well, thanks, Michael.
I can take it if you want.
It's very unfortunate that there is a line that separates, that is in between Red Hill and Crawley, which is the limit of the outer London fringe allowance. It's not set by the trust, and it's there. So therefore, if geographically you work inside that line, you get paid the fringe allowance. If you work on the other side of the line, you don't get paid the fringe allowance, and it reflects different estimates of the cost of living. So sadly, it's not within the trust's immediate control, and if you're working in Crawley, you don't qualify for the allowance.
Okay, thank you. I think that's the last question. So we're almost out of time anyway, so I think we'll draw a halt at that point. I'd like to thank everybody who's joined this live broadcast and asked such interesting questions, and I'd like to thank you all for the interest and support that you bring to the hospital. It's very valued. I'd also like to thank the panel here of Tony and Paul and Ed and Michael and Jane virtually for all of your contributions. I think most of all, I would like to thank all of our staff who have been through such challenging times and have brought such a high degree of professionalism and dedication in a way that just inspires, frankly. So I'm very, very grateful to all the excellent work that they do, and they should know that the whole board stands right behind them in trying to support them to the best of our ability so that they continue their excellent work. So thank you very much everyone for joining this evening. That is the end of this annual general meeting. Oh, and before we leave, I should just say that this is also Michael Wilson's last annual general meeting. It's either his 10th or his 11th, I'm not quite sure.
11th,
but I would like, he's been counting. I would like to, on behalf of the Trust and everyone who supports the Trust, I'd like to thank Michael for the superb job that he has done over 11 years in serving the people of this area through the work of the Trust. Thank you very much, Michael.
Yeah.
So that is now the end of the broadcast. Thank you.
Thank you, folks.